On behalf of the American Heart Association, I would like to welcome you to today's webinar, Hypertrophic Cardiomyopathy, Series Part 1, Unmasking HCM and Revealing Clinical Wisdoms. My name is Bianca Presley, and I am a Program Manager for the American Heart Association. This webinar is part of AHA's Hypertrophic Cardiomyopathy Initiative, Advancing Treatment Decisions for Patients with HCM. AHA's HCM educational content is made possible in part by a grant from Bristol Myers Squibb. I'd like to begin by going over a few items so you know how to participate in today's event. The link for live captions can be found in the question panel for your convenience. If you would like a copy of today's presentation, you can download a PDF from the handout section of your attendee control panel. If you experience technical difficulties, most users can be resolved by refreshing your browser. If that doesn't work, please review the system requirements or contact the GoToWebinar customer service team using the system requirement link found in your confirmation and email reminders. At the conclusion of today's presentation, you will receive a link to access today's recording, a completion certificate, and an invitation to complete our feedback survey. We welcome you to submit text questions for our presenters at any time in the questions pane of the control panel. We will collect your questions and address them during the Q&A session at the end of today's presentation. It is my pleasure to introduce our speakers for today, Heidi Salisbury, Cassidy Palmer, and Holly Andrews. Heidi co-founded the Stanford Center for Inherited Cardiovascular Disease in 2006 and is the program operations coordinator for the center. As a clinical nurse specialist, board certified in genetics, Heidi is dedicated to mentoring nurses, genetic counselors, and physician fellows to develop the clinical skills and gain the knowledge base necessary to adeptly manage patients with inherited heart disease. Heidi advocates building programmatic infrastructures that support a continuum of expert-level nursing care through the individual lifespan and across the generations of a family. Heidi has a background in exercise physiology and cardiac rehabilitation from Cal Poly San Luis Obispo. She completed graduate and postgraduate work in critical cardiovascular nursing science at San Francisco State, UCSF. Heidi is active in leadership roles with the Preventive Care Nurses Association, HCM Society, and American Heart Association. She enjoys spending time with her family and friends, exploring the outdoors, coaching youth soccer, and trying new things. Holly Andrews is a physician assistant working with the Hypertrophic Cardiomyopathy Clinic and the Advanced Heartfelt and Transplant Clinic within the Division of Cardiovascular Medicine at the University of Utah. Holly is originally from Colorado, attained her bachelor's degree from Brigham Young University in exercise science in 2010, and obtained her master's degree in physician assistant studies from Philadelphia University in 2014. She transitioned from working in otolaryngology in Colorado to transplant cardiology in Utah after her mother had a double lung transplant due to the desire to work in the life-changing field of transplant medicine. In 2018, Holly joined Dr. Weaver Penzon as the physician assistant in the Hypertrophic Cardiomyopathy Clinic. In 2022, she joined the ongoing research effort in hypertrophic cardiomyopathy as a sub-investigator with the desire to advance therapy options for patients with this lifelong disease. Cassidy Palmer attended the University of Cincinnati, where she majored in advanced medical imaging. Her program provided her with a well-rounded knowledge in the field of sonography and magnetic resonance imaging. Over the past 19 years in imaging, she has developed a keen interest in all things pertaining to cardiovascular medicine. She has founded her niche in clinical research and served as an integral team member of the Christ Hospital Imaging Research. She has also had the privilege to disseminate this research on national platforms, as well as publish numerous manuscripts, some of which she served as first author. Her passion is evident by her continued advancement in the field of echocardiography and cardiac magnetic resonance imaging. As a fellow of the American Society of Echocardiography, and fellow of American College of Cardiology. She served as a mentor for sonographers and fellow researchers. Heidi, the floor is yours.
Thank you so much, Bianca. Thank you, Renee, Liz, Justin, and the AHA for this opportunity to speak. I'm going to make sure I can advance these slides. I understand there's a 10-second delay for the first advancement. There we go. So again, my name is Heidi, and I'm the co-founder of the Stanford Center for Inherited Cardiovascular Disease, where I've taken care of individuals and families with inherited heart disease, such as hypertrophic cardiomyopathy, for 2 decades. I have no disclosures. Okay. I'm passionate about the heart, and I imagine that this is a passion I share with many of you. The heart, fascinating, can power the fastest person across the finish line, and at the same time imprison someone to their chair or affect a family such as this one with life-threatening heart disease across the generations. This is an exciting time in cardiovascular medicine. We've moved from the precision medicine initiative into the personalized and genomic era of medicine, where concepts such as gene therapy and gene editing are actually coming into clinical practice. There we go. Even with these scientific advancements, it's no news to the individuals in this meeting that heart disease remains a major threat to human beings, with it being the leading cause of death in America and in the world. Half of Americans have at least one of 3 key risk factors for heart disease: high blood pressure, high cholesterol, and smoking. But many heart-related deaths can't be explained by these risk factors, can't be explained by lifestyle and behavior. So what's happening there? Is there a genetic predisposition? Is it social determinants of health? Maybe a combination of both. When we talk about inherited heart disease, genetic heart disease, we often think about it being rare, kind of put this in this bucket of rare disease. Genetic heart disease is rare. But I just wanted to mind shift that for a second. If you actually look at, pull together all of the different types of genetic cardiovascular disease, such as hypertrophic cardiomyopathy, dilated cardiomyopathy, familial hypercholesterolemia, high cholesterol that runs in family, aortic disorders such as Marfan's, if you pull together the prevalence of all of those genetic diseases, what do you think the prevalence is, the pooled prevalence is? Is it 1 in 20, 1 in 200, 1 in 2,000, 1 in 20,000? And this is a little delay on these advancements. There we go. It's B, 1 in 200. And you know, it doesn't sound so rare anymore, does it? So what does the word cardiomyopathy mean? Cardiomyopathy is an umbrella term. Cardiomyopathy means a problem with the heart muscle and a problem with the pump and relaxation of the heart muscle. That's a pretty broad explanation. You can have primary or secondary cardiomyopathy. Primary can be used interchangeably with genetic. It means that you were born with either existing heart muscle disease or a predisposition to develop it as you grow. Secondary is the result of some other cause, lifestyle or behavior or social determinants of health. And listed here on this slide, listed here on this slide, we see some of the different types of cardiomyopathy and the incidence, the prevalence of these conditions. So the normal heart is first, hypertrophic cardiomyopathy is second, showing 1 in 200 to 1 in 500 individuals affected. Dilated cardiomyopathy, the weakening or enlargement of the heart muscle, 1 in 250 individuals to 1 in 2,500. Arrhythmogenic cardiomyopathy affecting the electrical system of the heart and can also have left or right ventricular involvement, is 1 in 5,000. Restrictive cardiomyopathy, stiff heart, and LV non-compaction, showing trabeculations in the left ventricle. We have guidelines now, specifically updated in 2020 by the American Heart Association, ACC, to help us diagnose and treat patients and families with hypertrophic cardiomyopathy. And I want to just bring to your attention and encourage you to take the time to review these guidelines and to pin or print or save on your phone the top 10 take-home messages that were curated from these guidelines. There are 10 top home take-home messages, and they're very thorough and really highlight the progress we've made in diagnosing, treating, and managing this patient population. I weave them into my slides, but I really encourage you to create a reference for yourself. What is hypertrophic cardiomyopathy? By definition, hypertrophic cardiomyopathy is the thickening of your left ventricular wall with no other identifiable cause. It is a genetic autosomal dominant disease, which means that 50%, every individual who has HCM has a genetic variant that in one gene that can result in their disease, and therefore they will have a 50% chance of passing it on to every offspring. And every individual in their family that they can touch on the family tree also has a 50% risk of either having the disease or a predisposition to developing the disease. The estimated prevalence in the population is actually 1 in 350 individuals. There's estimated to be 700,000 in the US, with only 100,000 knowing they have a diagnosis. And in some studies, there's upwards of 1 of 200 individuals who are genetic carriers. So in summary, it's underdiagnosed and misdiagnosed very often, which is a shame because it is, while it is a chronic condition with no cure, it is treatable. HCM, which we'll call it now moving forward, is associated with typically a normal lifespan, but the challenge is that it also is associated with an increased risk of ventricular arrhythmias and sudden cardiac death, an increased risk of atrial arrhythmias and stroke, and an increased risk of diastolic impairment and heart failure. What about hypertensive heart disease and left ventricular hypertrophy? We said that HCM is by definition the thickening of the left ventricular wall with no other apparent cause. And many of us on this call know that hypertension can make your muscle increase and therefore cause left ventricular hypertrophy associated with hypertension. So some pro tips here: when your heart thickens due to hypertension or poorly managed hypertension, the muscle will thicken in a very concentric, very uniform way. And it will also reverse, or the thickening will reverse when the blood pressure is better managed. The HCM heart, the thickening will not reverse when blood pressure is managed. It's independent. The thickening will stay thick. And in addition, the thickening is not uniform in the HCM heart. It's lumpy bumpy. It comes in different classic morphologies or shapes that are listed here. Sigmoidal is a sigmoid shape of the intraventricular wall. Reverse curvature looks almost like a crescent. Apical is thickness at the apex of the heart, and neutral HCM is a thickening of the entire intraventricular wall. I'm wondering if one of the moderators could advance the slides faster than I am, or I should still go. Let me know. Okay, there are two types of HCM in terms of hemodynamics: obstructive HCM and HCM without obstruction. What is obstruction? It is the obstruction of the flow of blood through the left ventricular outflow tract. So go ahead and take a look at the pictures here. Screen left is non-obstructive physiology. So you'll see the left ventricle, you'll see the thick wall and the smaller LV cavity, but you don't see any blockage of the flow of blood as it moves out of the left ventricular outflow tract from the LV out towards the aorta. In obstructive HCM, screen middle, you'll start to see, look at that, the red circle. You'll see areas where the physiology is actually, the morphology or the physical expression of the disease is actually causing obstruction of the flow of blood, either from the thick muscle or the abnormal long mitral valve leaflets obstructing the flow of blood. And then latent obstruction is a really important concept to spend some time thinking about. Latent obstruction means that at rest, look at that left ventricle, there's no blockage of the flow of blood, but with provocation or movement and exercise, you'll see, look at the little red circle, that you actually do get a narrowing of the left ventricular outflow tract and hemodynamic changes consistent with obstructive HCM. Why does this matter? It matters because obstructive HCM is associated with a higher symptom burden, reduced VO2 or exercise capacity, higher risk for atrial arrhythmias, and a higher risk for diastolic and systolic heart failure. Advance the slide. All right. Imagine, I want you just to imagine with me, just visualize a left ventricle with a very thick wall, small left ventricular cavity, and a very hyperdynamic, a very strong hyperdynamic muscle. Now dehydrate this heart, underfill this heart, reduce your preload, have a big meal, get a volume shift, and throw in some atrial fibrillation. This heart is going to struggle. You're going to see diastolic heart failure symptoms, shortness of breath. And so it's really important to wrap your mind around the underlying physiology of HCM and OHCM and think about it as a disease of with a small left ventricle, a thick hyperdynamic heart that's stiff when it relaxes and is preload dependent and very much favors being in sinus rhythm versus atrial arrhythmias. All right, next slide. Some clinical wisdoms. HCM symptoms, they typically don't happen at rest. And obstruction is in 2 out of 3 of patients with HCM. So it's really important for us as advocates for this patient population to work to get stress echocardiograms, ideally with gas exchange, VO2 gas exchange for our patients, so you can capture these hemodynamic changes and target their treatment. VO2 max measures the ability of our heart and lungs to meet the demand for oxygen under stress. And through this type of testing, you also can measure the blood pressure response and the heart rate response, both of which should rise with exercise, but sometimes don't. Sometimes it's blunted, or even your blood pressure, your heart rate are blunted or even drop. And those are very important things to capture in order to personalize the care of your patient with HCM. Next slide. Symptoms of HCM, classic symptoms of HCM, shortness of breath, chest pain, exercise intolerance, palpitations, dizziness, and peripheral edema. Traditional treatments for HCM. Holly's going to talk to you a lot today about risk stratification for sudden cardiac death and arrhythmias, and why these patients are particularly at risk for sudden cardiac death and arrhythmias and what we do about it. We're also going to touch on stroke prevention, symptom management, lifestyle behavior modifications, and your traditional gradient or left ventricular outflow tract reduction therapies with medicines or surgical interventions. Next slide. I'm going to skip this because Holly's going to dig in on risk stratification. All right, call to action here, everyone. Ooh, we're going to go back. Can we go back a slide? Nope. All right, there we go. You know what? I'm glad we went back and we're highlighting this slide, or we're not. We're going all over the place there. Can we just get to the stroke slide? There we go. Awesome. Well, good. It's getting the attention it deserves. This is the most important slide in my presentation. So one of the things that is really important to teach your patients and for those caring for this population is the risk for stroke is underappreciated, and it's real. Patients with HCM and patients with persistent or paroxysmal atrial fibrillation have a sufficiently increased risk of stroke. Well, HCM and AFib, they really go hand in hand. Your HCM patient, especially an obstructive HCM patient, with enlarged left atrium, has a increased risk of stroke upwards of 30%. Therefore, it's important to consider oral anticoagulation with direct oral anticoagulants or alternatively warfarin. Should absolutely be considered the default treatment option, ready for this, independent of CHA2DS2-VASc score. Because rapid atrial fibrillation is poorly tolerated in patients with HCM. You want to get them into sinus rhythm, and you want them to be protected from stroke. So really important take-home point for this population. Next slide. Educate your patients about why they're at risk for atrial and ventricular arrhythmias. Partner with them, because we only get them for, a half hour once every 6 months or so. So partner with them to self-monitor for the atrial and ventricular arrhythmias. Empower them to teach them on how to practice ongoing surveillance. Teach them about warning flags, such as SVT. That SVT is not so benign in this population. It should be considered a precursor for atrial arrhythmias and atrial fibrillation, especially if it's symptomatic. Palpitations that feel different. They know what heart symptoms are. We're looking for those ones that feel a little bit different. A change in their exercise tolerance or just their activities of daily living with no appreciable cause. The heart muscle doesn't change much in adults with HCM. Might stiffen up and there might be some challenges, sure, but it's arrhythmias that change. And so really teaching them and to each other, us as providers and caregivers for this population, about these symptoms, these flags, is empowering and is an important intervention. Don't be afraid to use your ambulatory telemetry, such as Zio patches and Holter monitors. And remember, we have wearables, some of which are FDA approved to monitor for atrial fibrillation. I've listed a few here, as well as the Cardia device. Next slide. Lifestyle and behavior. Increasingly, data affirms that the benefits of exercise on the general health can be extended to patients with HCM. This is a patient population that was historically benched and told, don't move, you could drop dead. We've moved away from that we would like our HCM patients to benefit from exercise. In fact, it's important that they benefit from exercise and just do so in a safe way. There's really not much associated high risk with exercise, and it's important to have a shared decision-making conversation around this with your patient, and that they in some way incorporate exercise and movement into their daily life. Next slide. Symptom management, lifestyle and behavior, quality of life evaluation and activities of daily living. Know the baseline for your patient. And know their heart and their physiology, and then help them work towards approach to incorporating physical activity safely into their life on a daily basis. If there are avoids for this patient, throw them on the table so everyone knows what they are and plan around them. Typically, it's high adrenaline producing activities, such as roller coasters or some extremely competitive sports. Hydration is key for this population, the majority of the population. And so really teaching your patients about why their hearts are preload dependent and hydration, and giving them hydration tips is key. And then telling them about additional support in the community, such as cardiac rehab programs, the Hypertrophic Cardiomyopathy Association, Preventative Care Nurses Association, peer support, and psychological support, so they can have support adapting and coping with their heart condition. Next slide. With symptom management, traditionally, there were no medications to treat the underlying disease. We only targeted the symptoms to optimize quality of life and to relax the stiff and hyperdynamic heart to optimize that filling time, because again, it's a small left ventricular cavity. We want to relax that stiff heart to optimize filling time, to improve preload, to support their hemodynamics and keep them in sinus rhythm. That's all we had for a while. We would use medications listed here on the right to accomplish those goals. Beta blockers, calcium channel blockers, ARBs, oral anticoagulation, disopyramide, sotalol, and GDMT if they had LV systolic function. But things have changed, and we'll talk about that in a moment. Next slide. Traditional non-medical intervention is the septal myectomy, which is actually a surgical technique where you open the chest, go into the left ventricle, and surgically remove the thick heart muscle, restoring hemodynamic blood flow, improving cardiac output for this patient population, and at times it involves addressing the mitral valve structure as well. Next slide. Non-surgical, but also an intervention, is alcohol septal ablation, which involves infusing alcohol into the septal wall, causing a myocardial infarction and therefore atrophying the thick part of the heart muscle. The anatomy has to be very specific for an individual to be a candidate for the alcohol septal ablation procedure, because the alcohol has to be able to reach the area that's thick. But this is an intervention for some patients. Next slide. Now, I hinted at some new treatments that for HCM. This is a very exciting time. On April 28, 2022, the first-in-class novel therapeutic that treats the underlying disease of HCM hit the market, published in Lancet. The medication is called mavacamten. It's part of a new class of medications called cardiac myosin inhibitors. The very first patient was dosed here at Stanford, and early research and development was inspired by real patient testimonials, where our patients would go in and sit in the conference rooms with scientists and tell their stories about their symptoms, about what it was like for them to live with obstructive hypertrophic cardiomyopathy. And years later, these scientists moved forward these treatment options, and now we have cardiac myosin inhibitors on the in play, and our patients are benefiting very much so from these medications. Next slide. So we're in a space now where we have a good problem. We've moved from potentially a treatable condition to a reversible condition with medications such as mavacamten and the new class of therapeutics, cardiac myosin inhibitors, that treat the underlying disease of HCM versus just treating the symptoms. We've learned in the last year and a half that there's some barriers to getting these new therapeutics to our patient populations, and I wanted to address some of those barriers so that we can learn together and continue to push things forward and get access to these novel therapeutics for our patients. Caution in terms of delaying to prescribe, because we're so worried that it might be expensive or it might be too hard for the patient to handle some of the additional testing for these medications. I would say that once you get the hang of it, the authorization process is no different than other authorization processes, and that patients feel so much better on the medication. They're very motivated to get through the extra testing. The national statistics on authorization and copay are encouraging, and most patients get coverage. And I just advocate for a proactive versus reactive authorization pathway so that you can get past some of these delays and get the medications to your patients that will make a difference in their life. Identify your stakeholders, your advanced practice team, your nurses, medical assistants, and pharmacists who can help build out a pathway for you to support authorization and management of these patients. Establish clear roles, competencies, and resources, training resources. Protect their time if you can. Get rid of the noise and all the worries and just focus on getting through the authorization process and getting these medications to your patients. And I promise you, it's so worth it. Next slide. In bridging off that excitement, the excitement of cardiac myosin inhibitors, just this last month, Tenaya Therapeutics dosed their first patient with a gene therapy in the MyPeak-1 phase 1b clinical trial using TN-201 molecule for the treatment or infusion for the treatment of MYBPC3 non-obstructive associated hypertrophic cardiomyopathy. So that patient number 1, has received the first gene therapy for HCM. Very exciting time. Next slide. A call to action. Consider a genetic evaluation for cardiomyopathy. HCM in particular, OHCM are greatly underdiagnosed and are now treatable and possibly reversible with novel therapeutics. And prepare your teams to have the diagnostic tools, the clinical competencies, and the practice infrastructure in place to ensure access, safety, and ongoing support for this very special patient population. Thank you so much. I'm going to hand it over to Cassidy, who's going to dig in on imaging for HCM. Thank you, Cassidy.
Thank you, Heidi. Thank you for that phenomenal review. Waiting for my slides to come. Will it automatically advance?
It's pretty slow.
Hi, Cassidy. You should have control now if you just click the slide. If not, I can take over.
I think I might need you to take over just to at least advance to that part. Thank you. Thank you. I want to thank the AHA for inviting me today to talk to you all on the topic of HCM imaging, specifics of recommendations and guidelines, and why all that matters, why quality matters. Next slide, please. I have no disclosures. So as piggybacking off of Heidi's introduction to the complexity of HCM, we see the different phenotypes that are often present in HCM. HCM affecting younger patient populations often present with the reverse and neutral phenotypes, which tend to have more prevalence towards a sarcomere mutation, as whereas older individuals often present with the basal or sigmoidal HCM phenotypes, as well as HCM phenotypes. Next slide, please. So over the last few years, we've seen not only updated guidelines for the diagnostic and treatment portions of HCM, but also updates to comprehensive imaging guidelines. So in today's talk, as an advanced cardiac sonographer, my focus is going to be on the imaging component of this. And since I'm kind of limited in time, it won't be an overly detailed conversation, but my purpose today is just to kind of highlight some key points and provide evidence of why comprehensive imaging is so important in reference to this material today. Next slide. So imaging, as we all know, has a very important role in HCM, which includes identification of phenotypes, as well as which patients present with the obstructive and non-obstructive forms of this disease, because these patients are treated differently based upon that. And most importantly, assessing them for sudden cardiac death. So this all comes down to quality on both echo and CMR levels, making a huge difference in the patient treatment as well as possible survival. Next slide. So again, speaking from my perspective of a sonographer, we're kind of the frontline people, so to speak, when assisting the physician to making or arriving at the correct diagnosis of HCM. So HCM specific protocols are key, as laid out here in this imaging strategy article that was actually published this year in JACE. Next slide. So the components of this HCM-driven specific protocol help us to know where to measure, when to measure. On our peristome long axis images, we want to have a standardized way of measuring these patients to make sure that we're capturing the LV wall thickness and chamber size correctly, as well as looking for presence of things such as systolic anterior motion, or SAM, which in this image at the bottom is M mode, which is actually a more sensitive marker for detecting that, as the temporal resolution compared to what we see on 2D can overlook SAM. Next slide. So here we have kind of some pearls learned, some examples from what sonographers have measured versus what the physician has remeasured. So in this example, the sonographer actually performed guideline-driven basal septal measurements, however, omitted the thickest part of the septum, as this was a reverse curved septum HCM phenotype. So it was important for the interpreting physician to also be aware and to perform re-perform measurements offline to make sure that the correct data was captured and reported correctly. So this also highlights the role of the physician reading to be aware of these phenotypes. Next slide. This is another example demonstrating the importance of not including chordal structures into the measurements during the time of echo. In fact, there's data shown that posterior wall thickness is also important when measuring HCM patients, as reports have shown or suggested that a posterior wall thickness or basal inferior wall thickness greater than 14 millimeters has predicted worse outcomes following myectomy. So we really want to make sure that we're taking the time to capture all measurements accurately. Next slide. We also rely on color Doppler to identify presence of any mitral valve regurgitation commonly associated with patients with SAM or systolic anterior motion. We need to be able to make sure that we can see if any of these jets are eccentric, so making sure that we take the time to really sweep or pan through the mitral apparatus is also important. Next slide. Sorry. We also, from a sonographer perspective, sometimes struggle to know if we are capturing the ventricular septal thickness accurately. This is a nice example of kind of a cross-check that we have at our peristernal short axis view. At the base of the heart, we can also remeasure as a cross-check. Next slide. As Heidi also highlighted, with the introduction of more myosin inhibitors in our patients, quantifying LVEF is key, especially as these patients undergo serial echoes. We want to make sure that they're not having any drops or changes in their LV ejection fraction, as well as looking for our end stage or burnout HCM patients as defined as an LVEF less than 50. Next slide. We want to also make sure that when we are documenting presence of such a hemodynamic disease, that we're looking and labeling the dynamic obstruction and making sure that this verbiage is included in the report, as this will help to also standardize reporting for patients and deliver the care that they need. Next slide, please. Provocative maneuvers should always be performed when HCM is suspected. It's advised to practice this maneuver in this imaging strategies article, just because sometimes patients don't fully understand how to perform Valsalva, so doing these beforehand can give us optimal data. We actually in our institution like to have two techniques that we go back and forth between, whether it be the typical asking the patient to bear down or having them blow against a closed fist. We just want to make sure that they're clear on how to actually get the best Valsalva maneuver possible. Next slide. GLS, or global longitudinal strain, is another tool in our tool belt and should be performed routinely. Next slide, please. Thank you. Areas of the thickest myocardium will typically demonstrate a greater reduction in strain values as seen in this image. At the level of the basal septum, basal anterior septum, we can see a more decreased strain in comparison to the other regions. within the patient's myocardium. Next slide. And that's all used to predict outcomes for these patients. So lower GLS predicts worse outcomes. And this really is no different than any other cardiac condition where reduced strain predicts outcomes. Next slide. It's important also to note that there is a different criteria for grading of diastology in these patients. Pulmonary vein flow, which is not included in the applied standard diastology algorithm from that 2016 guidelines from ASC. So it's important that the sonographer takes time to add those additional measures to get high quality pulmonary vein flow is paramount in diagnosing their grading. Next slide, please. Contrast echocardiography is also pivotal in defining endocardial definition for accurate quantification of LV ejection fraction, as well as ruling out presence of apical aneurysm, and as a cross-reference to accurately measure wall thickness in some cases. Next slide. HCM is important to remember that it's not only a disease that affects the ventricular myocardium or the mitral valve apparatus for that matter, but this disease also influences or affects the left atrial and RV myocardial portions of the heart. Left atrial myopathy is essentially seen in a majority of patients that Heidi also highlighted. These patients will present with reduced left atrial function as assessed by left atrial strain parameters. Left atrial ejection fraction correlates very nicely with fibrosis that's seen on cardiac MRI in the left atrium. And so as a standard in our institution, we report left atrial strain. This is much faster than acquiring and analyzing left atrial fibrosis by 3D LGE, which is what we see in the corner. That rotating image is a reconstruction of a person's left atrium. The red color is a core scar, whereas the blue is healthy tissue. So these patients are at higher risk because now they have replacement fibrosis in their left atrial tissue. Next slide, please. Left atrial function also has, assessing it has a twofold importance as it aids to help identify patients at risk for AFib. As was mentioned, AFib in these patients have catastrophic consequences. They can't compensate with not being in sinus rhythm. So in our institution, we recommend, as Heidi brought out, the patient to wear these wearable devices to be able to detect AFib when we see left atrial myopathy present by left atrial strain abnormalities on their cardiac MRI. In addition, we can also use this to help assess or grade their diastology and also use it to predict progression of heart failure, which is demonstrated in this slide. Next slide. So as a sonographer, my ultimate responsibility for our HCM patients is to keep them alive. And we do that by helping to identify certain risk features or for sudden cardiac death by echo. These include looking for severity of LV hypertrophy, a septum that's thicker than 30 millimeters, as well as burnout LVEF less than 50. In addition to, is there a presence of an apical aneurysm? In addition, we use LGE by CMR, or late gadolinium enhancement, to also grade these patients. A late quantification of a LGE of greater than 15% by CMR is, however, currently only a 2B indication, even though it's been linked to increased ICD shocks in these patients. Next slide. So when we talk about fibrosis, what are we specifically making reference to? So this model, which I really like, shows a breakdown in the types of fibrosis that can be present. You can have mid-wall within the mid layer of the myocardium, as well as transmural through all three layers, or subepicardial LGE. Next slide. Thank you. So all types of fibrosis can be present in HCM patients, as this example shows. In our institution, We do give pause to patients with subendocardial and transmural LGE. They warrant further evaluation for ischemic evaluation as well. Next slide. This is an example of some additional sequences that can be run at the time of cardiac MRI. This is parametric mapping, or what we refer to here as ECV, or extracellular volume. This is another asset to be able to grade presence or absence of interstitial fibrosis that otherwise might be missed on late gadolinium enhancement imaging. To the far left, you see a normal ECV, and what we're looking for is a nice complete ring of lime green color. As you progressively go through the different histology samples, you see the type of color change within that green ring. It goes from a nice green to a soft yellow to an orange to a red, and finally to that crimson red where we see a complete replacement scar. Next slide, please. Apical HCM is being diagnosed more frequently as physicians are becoming more aware of unique ECG patterns with those, as you can see to the left, those deep precordial T wave inversions. More frequently, we're using contrast echocardiography, as well as other advanced imaging techniques such as CT and MR. In the past, this condition was thought to be benign, but now we're realizing that it has an actual increased risk for sudden cardiac death. And this is related to the apical aneurysm, related to the VT that often arises at the junction of the aneurysm and the apical myocardium, which leads the patient to increased risk for stroke. Next slide, please. Another part of the anatomy that should be given attention are the papillary muscles. The PAPs can actually play a role in the pathophysiology of a dynamic obstruction in these patients. And it's also important for us to note and highlight this in the report for any pre-procedural planning, especially if there's consideration of alcohol septal ablation or myectomy, as this often would not likely be effective in reducing that obstruction. The surgeon might have to actually do something to the papillary muscles as well. In addition, at this point, we're not certain how myosin inhibitors really influence that papillary muscle anatomy, but I'm sure there'll be more to come. Next slide, please. I like this distribution slide showing the variations in papillary muscles in HCM. Patients can actually have multiple papillary muscle heads. The papillary muscle heads themselves can be hypertrophied, or they can be displaced, contributing again to that pathophysiology of the dynamic obstruction. Next slide. So small vessel disease is also seen in majority of these patients. So what we typically see is an ischemic-like pattern or defect by nuke or stress CMR. And these defects often precede LVH in patients with a mutation that are mutation carriers. So it's important to highlight this prior to the progression of their disease. Next slide, please. This is a sequence that we do at the time of our cardiac MRIs on these patients. This is cardiac MRI 40 flow. This can be useful in identifying areas of obstruction, although we're not currently using this technique to quantify any severity of the LVOT gradient. It just helps us to give a visual placement of where that obstruction would occur. Next slide. So the importance of echo guidance during alcohol septal ablations cannot be overly emphasized. It's important that the interventionalist see this culprit myocardium area to make sure that we're using alcohol and delivering it in the optimal area. Next slide. As highlighted in this case, where the alcohol was not delivered in the culprit area, and so the sigmoid was actually spared, and the LVOT gradient actually increased in this patient, and they had to go for additional invasive procedures to correct this. Next slide. This is an example of what to be mindful for when your patients return for follow-up imaging following some of these interventions. So following alcohol septal ablation, most commonly you will see some type of transmural LGE at the level of that ablation, whereas post-myectomy, we would not anticipate seeing any type of LGE in that region. Next area. Slide. Sorry.
Cassidy, I'm sorry to interrupt. I'm just going to move to your final slide. Just in
okay. For time.
Sorry.
Okay.
Yes, go ahead.
So finally, why all this matters is outcomes. It's because of a multidisciplinary approach that we are able to actually improve outcomes compared to the general population. And that's it. Sorry. So now I want to give attention to our final speaker, Holly Andrews. Thank you.
Thank you so much, Cassidy and Heidi. Your talks were fantastic. And thank you to the HA for this opportunity to speak. Both Heidi and Cassidy actually touched a little bit on symptoms for HCM, or a lot on symptoms already for HCM, so I don't need to go through all of that. So I'm going to focus mostly on just the sudden cardiac death aspect of this disease. It happens fairly rarely for these patients. It happens about 1% of patients who have HCM each year. However, that's 1% that this is happening to. And it is a devastating thing to have happen in our lives, or any patient's life, to have a sudden death event of for themselves, for their families, for anything. So we talk about ways that we can screen for that and see who might be at risk for this very, very detrimental possibility for this disease. And we have ways to look into that. And then I've been trying to advance this. Oh, there we go. Okay. So for HCM in general, on this side, Cassidy had two. When someone's diagnosed with HCM, you can see the first thing on the phenotype side that says a sudden cardiac death risk evaluation. And we pulled this figure from the guidelines. And so that's one of the biggest things we have to look at. And it's not a one-time thing. We have to reevaluate this risk for sudden death over and over. So we see them at their initial evaluation and do their initial testing. And then yearly, when we see these patients, we get an EKG. Every 1 to 2 years, we're getting a Holter monitor. Every 1 to 5 years, depending on what's going on with the patients, we're getting more imaging. And so we're constantly reevaluating this risk. It's not a one-time thing. How we prevent somebody from having sudden cardiac death is we put an ICD in. So the question is, if this is a risk for this disease, why don't we put a defibrillator in everyone? And the reason is the risk of defibrillator complications is higher than we would expect. It's 4%. So you can have infection. You can have one of the leads that are in there break. If you think about this disease being diagnosed in a 20-year-old and we put a defibrillator in, they have easily, 50, 60 more years of life with this defibrillator in place that they can have complications for. And every 10 years, they need a new battery. So we don't put them in everyone. So we have to find a way to risk stratify who's at risk for dying suddenly and who should have a defibrillator. So in the United States, we look at these 7 characteristics. Cassie went over them in hers. I'm going to go over them individually too. And then also, if patients have had an event where they had a cardiac arrest, they had sustained ventricular tachycardia, we give them a defibrillator for secondary prevention because they've already had it. So we're talking about primary prevention of dying suddenly for these patients. So the first one I want to look at is family history of sudden death. So usually this means more in a first-degree relative, so a parent, your sibling, or your child. But if you have multiple second-degree relatives who have this going on too, then that's something to watch as well. And then it also, so not just a sudden death event, but something we also look at if you have a sibling who has been diagnosed with HCM and they have had a defibrillator placed and their defibrillator has gone off because of sustained ventricular tachycardia, that counts in this as a sudden death event, because without that defibrillator, that would have been a sudden death event for them. So down here, what I have is a genealogy chart for a patient from our clinic. The arrow is pointing to them. And what we're looking at, there's 9 siblings here, and of those 9 siblings, 3 of them have had sudden death events. And so this patient got a defibrillator because they had 3, they only needed 1. They only needed 1 first-degree relative who had sudden death, and this patient had 3. So there was a primary prevention defibrillator that went in for this patient. The next one is LV wall thickness. So the thicker the heart gets, the more problems we see with the heart. And really our cutoff for this is 3 centimeters. If you look at the graph on the left, though, it's, you know, saying 3 centimeters is the cutoff. Yes, that's where we say, hey, we should consider a defibrillator. But if somebody has 28 millimeters, they're at risk too. It's a whole stratification. We have to watch it and talk about their other risk factors that they have as well. It matters more, actually more often in younger people. So if someone in their 20s has a wall thickness of 3 centimeters, that's a big deal because they develop that within the first 20 years of their life. If someone we followed with HCM and they develop it a little bit later on, still significant, but some of the age matters here a lot more for diagnosis of this. So the thicker the wall is, the earlier it is, the bigger problem we see throughout their lives. The next one is unexplained syncope, so passing out for no reason. It matters more if this has happened in the last 6 months leading up to when you see them in clinic. And it's more predictive for patients who are younger than 30 years, although we still use it for patients of all age. If it's recurrent, this is happening a lot where they're passing out, that's a big deal. Now, if somebody tells you that they passed out a bunch in elementary school and now they're in college, it's over 5 years. We don't look at that as much. It matters more within the most recent time period. So if someone is passing out suddenly, it's something to keep in mind, and it is a risk factor for sudden death. Next risk factor is presence of an apical aneurysm, and Cassidy did a great job of going over that with the imaging side of things. What we know, if an aneurysm is present, no matter to the size, it doesn't matter if it's small, medium, large, it doesn't matter. If they have the presence of one, we're finding that they have a 5-fold higher rate of dying suddenly. So if we're seeing that on imaging, we're having a discussion about placing a defibrillator with these patients. The next one, oh, sorry, here's a picture of those. Cassidy already did that, but it was small, medium, and large apical aneurysm. The next one is an ejection fraction less than 50%. This was new for the updated guidelines in 2020 compared to the previous guidelines. And so we found that if patients have an ejection fraction less than 50%, they have a 5-fold higher rate of having a sudden death event. Now, in HCM-related deaths in general, which those can be from, you know, development going into heart failure, needing advanced therapies. But in HCM-related mortality in general, we have a 10-fold higher rate of death in patients who their ejection fraction is less than 50. So this is a big deal. That's why we do all the imaging modality, the MRIs, the echocardiograms, and we do them periodically to evaluate the patient's risk. Because if that ejection fraction is falling, it is a big deal. The next one is non-sustained ventricular tachycardia. We get Holter monitors, cardiac monitoring for this. What an SVT is defined as is 3 or more beats, and they have to be at least 120 beats per minute for how fast they're going. This matters more, again, young age population, because sudden death is the leading cause of death in young athletes from a heart, an inherited cardiomyopathy reason. So it matters more in young. And then it's more significant if you have more, if they're happening more frequently. So when on a cardiac monitor, if you have more than 3 of them, if they're longer occurrences, so 10 or more beats, and if they're faster, getting up to 200 beats per minute. And so this risk factor is a 2B classification, and we'll go over, I've got a little screen on the next page, but because it matters more if you just have one event of NSVT, it's 3 beats and it was pretty slow, like 122 beats per minute. You know, the whole risk stratification was a discussion with your patient to go over, hey, this is happening, let's watch and see, or, you know, you have all these other risk factors. So we weigh them based on what else is happening for the patient. The next one is late gadolinium enhancement that, again, Cassidy went over with her imaging. So we look at it as 15% late gadolinium enhancement or more is a really big deal. And we see that when this is present, they have a 2-fold risk of sudden cardiac death. Now, most patients who have HCM will develop some form of LGE. Usually it's around 1 to 2% is pretty average. So greater than 50% of patients have at least some of this fibrosis going on. It just depends on the amount of it, and 15% is our cutoff. Next one, oh, sorry, here's a picture for patients in our clinic. On the left side of the screen, we had a patient who had no LGE on their MRI. So what you're looking at is the black donut, essentially, they're saying is the myocardium. And you can see how it's beautiful black tissue. There's no speckling going on in it. So there was 0% of the myocardium had the late gadolinium enhancement. On the right side, this patient, they had 42% late gadolinium enhancement. Now this patient, we got the results of their MRI that day in clinic, and we walked down the hall to our electrophysiology department. So we said, we really need to talk about sudden death here and the idea of a defibrillator because of how much fibrosis there is in the heart. Now, who does undergo ICD? At the beginning, I talked about how not everybody gets one. This was taken from the guidelines, and it looks at, so the first 5 that I went over: family history, massive LVH, unexplained syncope, the presence of an aneurysm, and an EF less than 50%. That's a class 2A indication. So if any one of those, you don't have to have multiple, 3, 5, just one of those is present, it's necessary to have the discussion with your patient about a defibrillator to discuss their thoughts. And this is a joint decision making with your patients. In SVT, we talked about how it varies. It depends on how frequent, how fast, how long it's happening. But this is a class 2B indication for adults. And then extensive LG on the MRI, also 2B, but I think that as studies come out more and more about the prevalence of fibrosis in the heart, that this might change. But for right now, any of these, though, are worth having the discussion about, hey, we might want to talk about protection from sudden death because you're at higher risk than your counterparts with this disease. That's the American side of things. The European guidelines, they have a slightly different risk stratification. They add age, left atrial diameter, and then left ventricular outflow tract obstruction into their risk calculator for coming up with an idea for who's at risk for sudden death. And with that calculator, you can see here, it gives them a percentage. And based on that, it puts them in low risk, intermediate risk, high risk for an ICD. This risk calculator is really, really good for identifying those who are at high risk and even intermediate risk. We lose some of the patients who equal low risk when they get into that category, and some of them are still having some of these sudden death events. So no matter what we're seeing is this is a complicated thing. There's no perfect risk calculator between the ones that we use on the American side, the ones that the European risk calculators. They're both really great tools, and still it's a discussion with your patient. So a little bit, Cassidy covered some of this too. So a lot of what's coming next, sometime in our institution too, we're looking at maybe cardiac MRI strain measurements could play a role. We don't know yet, but looking at areas where the LG is located and then what's going on with strain. And then one of the other ones looking into is myocardial disarray. So essentially the space between cells, and is there an idea of, is this, can we measure it to give a reasonable risk stratification versus what we already have with late gadolinium enhancement. So in summary, HCM, we have the risk of sudden death. While again, it's about 1% of all patients that have it happen each year, it's still 1% of the patients that have it each year. And we can look at who might be at risk for that and prevent it. So the decision for ICD needs to be made carefully between the patient and the provider. Again, they only need one risk factor. If there's more, that's something we really need to watch and look into. And looking at both the American side of things, the European guidelines, all of them can play a role in our risk stratification for this. Just to hit it again, a lot of these have to do more with the younger patients. Sudden cardiac death is devastating no matter what age you are, but sudden death affects a lot of times the young, so our most productive age group and population in society. So it's very, very important to do this risk stratification for all of our patients who are diagnosed with HCM.
Thank you, Heidi, Cassidy, and Holly for leading today's webinar. And thank you to our registrants that were able to stay on a little longer than the designated time. This webinar is part of the AHA Hypertrophic Cardiomyopathy Initiative. Again, we want to thank you for your participation in today's event. After today's webinar, you will receive a follow-up email with a survey on the presentation, and we would appreciate it if you would complete that and provide your feedback. In that email, you will also receive a link to view a recording of today's presentation and a certificate of completion. On behalf of the American Heart Association, thank you for joining us and have a great day. This concludes today's presentation.